Hi, my name is Chris Carey, and I'm a child, adolescent, and adult psychiatrist at the Lurie Center for Autism with Massachusetts General Hospital for Children with Harvard Medical School. So let's start with an overview of important clinical facts to know about for the clinician caring for a kid, child, or an adult with autism spectrum disorder. Autism is best thought of as a heterogeneous behavioral phenotype. By that, I mean autism likely has a wide variety of different causes. We're likely talking about a variety of different conditions that we all kind of understand under this rubric of autism spectrum disorder. But it is a clinical diagnosis. There's not a blood test or a imaging test that's used to aid in diagnosis, though the diagnosis likely has a neurodevelopmental, neurologic component that causes it. It's still a diagnosis that's made based on a clinical interview and a review of the developmental history for a patient. That means that in children, teenagers, or even adults, an approach to a diagnosis is an interview with an expert in autism who is able to elicit and identify symptoms of social challenges and restricted repetitive patterns of behavior, as well as a careful assessment of the developmental history for that individual, even in adults. It is expected that individuals with autism spectrum disorder have symptoms of that condition on a lifelong basis, starting in early development. Even individuals with higher functioning autism spectrum disorder are expected to have identifiable symptoms of their autism, though they may be milder in higher functioning patients. The symptoms of their autism are expected to be seen in early development. We might think 2, 3, 4, 5, 6 years old, although in patients with higher functioning autism, those symptoms might come into starkest relief in the preteen or teenage time periods. But the symptoms are expected to be there going back to early development. There are currently no medications that improve the core symptoms of autism spectrum disorder or alter life course. We're going to talk about medications today that have to do with treating behavioral comorbidities or psychiatric comorbidities. But there's no medication per se for the core symptoms of autism at this time. Treatment for autism is behavioral and educational, as well as therapies, including physical therapy, occupational therapy, and speech therapy. It's important for the clinician to know about medical comorbidities that are more common in patients with autism spectrum disorder. Epilepsy, at one point you could easily say, was about a third of patients with autism. Those numbers are decreasing as higher functioning patients with autism represent a larger portion. Patients who have autism spectrum disorder with co-occurring intellectual disability are more likely to have epilepsy. An individual is more likely to have epilepsy if they're female with autism, if they were very premature, or if they belonged to families with multiple individuals with autism. All those are risk factors for higher rates of epilepsy. Constipation is a common comorbidity in autism and can sometimes underlie behavioral concerns, as can gastroesophageal reflux disease or inflammation of the esophagus caused by conditions such as eosinophilic esophagitis. About 1/3 of patients with autism can have hearing loss, with also a large proportion, up to 40%, having visual problems, which may include strabismus or amblyopia. Intellectual disability is an important comorbidity for patients with autism spectrum disorder. As we're understanding and diagnosing individuals with autism spectrum disorder who are higher functioning in their lives more and more over the past few decades, patients with autism without intellectual disability now represent a little over half of all patients with autism. About a third of patients with autism spectrum disorder have some components of language impairment, which might range from patients who are completely nonverbal to patients who use language in a non-communicative fashion, for instance, with echolalia that might be repeating of a certain phrase over and over again, or scripting speech from a favorite TV show or movie, to patients who have fluency in terms of their language, but struggle with the pragmatic usage of language on a day-to-day basis. It's a condition with a strong genetic component to it. It is among the most heritable within families of all diagnoses in the DSM, up there with ADHD. And some important heritability information to talk about with autism spectrum disorder. Among males with autism spectrum disorder, there's a 58% chance of monozygotic twins, both having autism spectrum disorder, while a 20% chance of dizygotic twins having autism spectrum disorder. When it comes to females, a 60% chance of both twins, monozygotic twins, having autism, and a 27% chance in dizygotic twins. The chances of having a second child with autism spectrum disorder, if your first child has autism, is between 5 and 20%. That rate is higher if the first child with autism is female. And if there have been two children who both had autism, it's about a 1 in 3 chance that the third child will have autism. All these issues highlight the high genetic heritability in this condition. There is higher rates of diagnosis of autism in males as compared to females of between 4 to 1 and 5 to 1. Those numbers get much more oriented towards males of up to 20 to 1 when it comes to higher functioning patients with autism, leading many clinicians to think there may be a diagnostic bias against women being diagnosed with autism that might partially explain this, that perhaps we're not diagnosing women who have autism. It's important to talk about some non-medication-based interventions for behavioral concerns in autism before we launch into talking about how medications can be helpful for behaviors. It's important to emphasize adequate sleep and exercise for kids, teens, and adults that have autism spectrum disorder. These issues can very much help with hyperactivity on a day-to-day basis. It's important for the clinician to evaluate for medical underlying conditions that might explain behavioral concerns, particularly in minimally verbal patients with autism. Constipation, esophageal reflux, dental problems, dysmenorrhea, and post-ictal confusion or sedation, behaviors that can be seen after a seizure. All of these things can result in behavioral changes. It's important for the clinician to be thinking about these issues before moving to think about psychopharmacology. Occupational therapists in or outside of the school environment can help with behavioral concerns related to hyperactivity. They can identify triggers for anxiety or irritability, and they can sometimes design a number of calming sensory interventions that can help, particularly with repetitive sensory-seeking behaviors such as stereotypy. It's important to focus on maximizing communication in children with autism spectrum disorder that are minimally verbal, and ensuring that kids, teens, and even adults with autism spectrum disorder have chances at speech therapy focused on augmentative alternative communication strategies, AAC. That might include the usage of tablets with a program on it where individuals press a button and it verbalizes a request to take a break, for instance, or to indicate if someone is in pain, or using tablets to institute a visual schedule. Essentially, individuals who have some way to communicate frustration, that can be an important coping skill that can be as helpful as any medication that's prescribed. Behavioral therapy, the most common behavioral therapy is applied behavioral analysis, ABA, can be very helpful in terms of understanding the precipitants of challenging behavior, identifying if they're attention-seeking or have to do with anger management, for instance, or seem completely unrelated to the outside environment. It can be very helpful to the prescribing clinician to collaborate with a behavioral therapist. When they institute a medication, they can ask to review data taken by an ABA team to identify whether there's been a positive response to medications. With any new behavioral approach that's instituted, it's not unusual for there to be a 1 week to 2 week period where behaviors get worse before they improve. Preparing families for this possibility and not giving up on behavioral therapy is important. Finally, I'll mention that patients with autism spectrum disorder should be offered psychotherapy, just as your neurotypical patients. I like to evaluate whether patients can identify emotional content and connect it to events that may be happening in their life. If they can, then psychotherapy can be helpful for them as well. Some patients with autism spectrum disorder may benefit from more structured therapy that might come from cognitive behavioral therapy, or have more parental involvement in their therapy at an older age than you'd expect, for instance, into the teenage years or even young adult years, to ensure that that therapy is as effective as possible. I'll finally finish up this video with when to consider pharmacotherapy. If there's a lack of any behavioral treatments that are effective, if there's a concern about the safety at home or with siblings, if there's no amount of preparation that can make a community trip safe, or if an individual is not eligible for a day program or in-home care staff due to safety concerns, or if it's not safe to place any demands on an individual with autism. A couple key points to take home from this overview of autism. Autism spectrum disorder is a lifelong neurodevelopmental disorder with a strong genetic heritability. Common medical comorbidities in autism include epilepsy, gastroesophageal reflux, constipation, and dental problems. Behavioral therapies and, when appropriate, psychological therapies should be offered to patients with autism, in addition to medication-based treatments for behavioral and mental health concerns. Next, we're going to talk about the treatment of motor hyperactivity and inattention in patients with autism spectrum disorder, specifically psychostimulants. We're going to start talking about a case. A is a 7-year-old boy with autism spectrum disorder, and a major concern brought forth on the part of the parents was frequent stereotypy and ritualized play. At baseline, A has constant need to move and explore. He's easily distracted at school, despite numerous accommodations placed in part of the school. In the appointment with A, he has a constant need to move around the room, be redirected to stay in the office and take apart things in the examiner's room. He can't sit still for any prolonged period of time for any of his therapies at school, such as occupational therapy or speech therapy, and the need to take constant movement breaks very much limits the progress he can make. Any period of time where there's less structure, A engages in repetitive silly behavior and hyperactivity, which makes management very difficult. This constant silly limit testing behavior and destructive curiosity, taking things apart, makes community trips very difficult. So let's talk a little bit about the treatment for hyperactivity and inattention in patients with autism spectrum disorder. We'll talk first about stimulant medications, which fall into two major categories: methylphenidate products and mixed amphetamine salts, which serve to increase dopaminergic tone in frontal lobe regions of the brain. I'm going to start with telling you about an important trial that was done by the RUB group of methylphenidate for the treatment of hyperactivity in kids with autism. This first trial I'm telling you about was done in 72 children, ages between 5 and 14 years old. To participate in this trial, you had to have significant ADHD symptoms in addition to an autism diagnosis, with the full range of severity of autism spectrum disorder, from higher functioning to lower functioning individuals with co-occurring intellectual disability. The study design was a 4-week double-blind placebo-controlled trial with a 7-day lead-in period where subjects had a test dose, ensuring they could tolerate the stimulant medication. In the 4-week double-blind placebo-controlled component of the trial, for each week, subjects were on a different dose level of methylphenidate or a placebo. So those 3 dosage levels were 1.25 milligrams per kilogram, a quarter milligram per kilogram, or half a milligram per kilogram, corresponding to a mild, moderate, or high dosage. And that was dosing using immediate release on a 3 times a day dosing schedule. And then the fourth potential was placebo. So clinicians and subjects and their caregivers did not know what dosage the individual was taking or whether they were on placebo. The results of the trial showed that individuals taking methylphenidate were more likely to have reductions in hyperactivity as measured on the ABC, the Aberrant Behavioral Checklist hyperactivity subscale, as compared to placebo. And that was as rated by both parents and teachers that were blinded to whether an individual was on medication or not. There was about a 50% response rate to methylphenidate among children with autism. It was judged that 35 of the subjects taking methylphenidate were responders as compared to only 9 taking placebo. And this was judged to be a positive trial attesting to the efficacy of methylphenidate for the treatment of hyperactivity in kids with autism. A large number of subjects had to drop out of the trial due to adverse events, about 18% of subjects, which is high for a trial. The reasons individuals had to drop out had to do with increased irritability, insomnia, or decreased appetite. Another important side effect that was seen in this patient population was social withdrawal. Social withdrawal is obviously a big concern in this patient population because social challenges are already a big issue. So any side effect that could decrease an individual's social interest or make their social withdrawal worse is a problematic side effect in autism. That was a dose-dependent side effect. So the higher the dosage of the methylphenidate, the bigger risk for social withdrawal. Social withdrawal is an important side effect to watch for when prescribing stimulants in children with autism spectrum disorder. There was a follow-up trial that was done in 2017 that showed better tolerability with long-acting methylphenidate. There was a smaller number of subjects that had to drop out. It was a smaller trial, but it suggests perhaps long-acting forms of stimulants may be more tolerable. in patients with autism spectrum disorder. The clinical approach to the treatment of motor hyperactivity and inattention should include methylphenidate and mixed amphetamine salts. If there are already co-occurring issues with irritability, that might make a clinician think about the usage of these other non-stimulant medications before stimulants. Clinicians may consider alternative medications such as alpha agonists or atomoxetine. So some key points to take home. Psychostimulants can be effective in reducing hyperactivity among the full range of severity of autism spectrum disorder, both higher functioning individuals and individuals with substantial co-occurring intellectual disability. Research suggests a higher rate of tolerability difficulties with stimulant medications than seen in neurotypical children who have commensurate levels of hyperactivity and inattention. Social withdrawal is a dose-dependent side effect to watch for when prescribing stimulants in children with autism spectrum disorder. Next, we're going to talk about the treatment of motor hyperactivity and inattention in patients with autism spectrum disorder, specifically non-stimulant medications. Just to review, non-stimulant medications for the treatment of ADHD symptoms include alpha-2 agonist medications. These medicines agonize alpha-2 receptors, which are thought to have downstream effects in increasing norepinephrine that increase dopamine in frontal lobe regions of the brain. These medications can have more sedating effects and therefore can be helpful for hyperactivity. Other medicine to talk about that's non-stimulant is atomoxetine. This medication blocks the reuptake of norepinephrine, which is also thought to have downstream effects on dopamine. The first trial I want to talk with you about today is a double-blind placebo-controlled trial of atomoxetine for the treatment of ADHD in children and teenagers with autism spectrum disorder. This was an 8-week trial that was done in 97 subjects with autism. Age range was 6 to 17 years with a mean age between 9 and 10. Individuals with mild intellectual disability could also participate in the trial. The trial design followed a 3-week titration where individuals started atomoxetine 0.5 milligram per kilogram per day, then increased to 0.8 milligrams per kilogram per day, then 1.2 milligrams per kilogram per day, which was the target dosage. And it was a double-blind placebo-controlled trial, so were compared to individuals who took placebo. So let's talk about the findings for this trial. This trial looked at the reduction in the score of the ADHD rating scale as their primary outcome measure. I'll just walk you through this table here. You'll see that the column on the far left shows the total ADHD rating scale score, and then it breaks it up by inattentive symptoms and hyperactive symptoms. And you'll see that the reduction in the score of ADHD rating scale is superior in ADHD total, inattentive symptoms, and hyperactive symptoms in atomoxetine as compared to placebo. So in all three of those components measuring ADHD, there were reductions that were superior to placebo. The reductions in hyperactivity were more notable than the reductions in inattention. The magnitude of reduction in ADHD rating scales in this trial was not particularly impressive as compared to the magnitude of reduction of ADHD symptoms in neurotypical kids. So this is a magnitude of effect of 8.2 as compared to a magnitude of effect of 13 to 19 in trials of ADHD in neurotypical patients. This relatively less magnitude of effect is also emphasized in the next finding here. They also did a CGI-I looking at whether somebody was a responder, which is to say very much improved or much improved as compared to placebo. Clinical Global Impression Improvement Score. This is another commonly used outcome measure in trials where clinicians are asked to essentially just say, is this individual improved or not improved, and then rate what that level of improvement or worsening. If you tabulate the number of subjects taking atomoxetine that were very much improved or much improved compared to placebo, this was not a significant difference. So that tempers a little bit of our excitement on the findings of this trial. Let's next move to talking about side effects related to atomoxetine. So the side effects that differed from placebo were nausea, decreased appetite, and fatigue, all more common in atomoxetine as compared to placebo. Moving on to the next trial, which was of extended-release guanfacine in individuals with autism spectrum disorder. This was another double-blind placebo-controlled trial. It was an 8-week study of 62 subjects with autism. These were all subjects who did not have co-occurring intellectual disability. Age range 5 to 14 years old. The dosing for this trial was flexible, so clinicians increased the dosage as high as they could go within a range of extended-release guanfacine of 1 to 4 milligrams, stopping at the dosage that was the balance between most effective and most tolerable, and most commonly landed on a dosage of extended-release guanfacine of 3 milligrams per day. This next figure here shows you the reduction in hyperactivity using the ABC hyperactivity scale. You can see looking at this figure here, the squares refer to individuals taking placebo, the circle refers to individuals taking guanfacine. And by 2 weeks of taking guanfacine, you'll see that there is a reduction in hyperactivity that is significantly different than placebo. And that continues to reduce out to 4 weeks and then kind of plateaus out to 8 weeks, which is the duration of the trial. So by 4 weeks, you had a pretty good sense of whether someone was improved with guanfacine as compared to placebo. There was a 43% decline in scores of hyperactivity on the ABC hyperactivity subscale as compared to only a 13.2% decrease with placebo. And they also did a CGI-I, looking at whether somebody was a responder, which is to say very much improved or much improved, as compared to placebo. And 50% of subjects were very much improved or much improved on the CGI-I, as compared to only about 9.4% for placebo. So definitely a positive trial attesting to the benefit of guanfacine. Adverse events of extended-release guanfacine included drowsiness, fatigue, emotional fragility. We might think about that as being increased emotional lability, and irritability. This study measured blood pressure changes and pulse changes. They did find small decreases in blood pressure and heart rate. However, blood pressure returned to pre-treatment baselines by the end of the 8-week trial. There have been smaller trials looking at clonidine, 2 small placebo-controlled trials that have both showed benefit in reducing hyperactivity, and an open-label trial of immediate-release guanfacine was a positive trial, suggesting that immediate-release guanfacine may also be helpful. Alpha agonists for hyperactivity should be especially considered in patients with existing problems with irritability, where there's a concern the stimulant may worsen irritability. That appears to be much less likely to happen with alpha agonist medications. Alpha agonists may also be considered in patients who can't tolerate stimulants for other reasons, such as weight loss. Alpha-2 agonists can have a calming effect as they inhibit the release of norepinephrine, decreasing hyperactivity, and may even have some effect on anxiety. And so these medications may be considered, especially where hyperactivity is combined with challenges with emotional regulation. So to sum up, the treatment of motor hyperactivity and inattention in patients with autism spectrum disorder who have existing problems with irritability may start with alpha agonist medications or even atomoxetine before moving to stimulant medications. A couple of key points to take away from this information here is that alpha-2 agonist medications and atomoxetine suggest improvement in hyperactive symptoms in children, teens with autism spectrum disorder with superior tolerability to stimulants. Improvement in ADHD symptoms in children and adolescents with atomoxetine is better for hyperactive symptoms as compared to inattentive symptoms. Improvement with atomoxetine in ADHD symptoms for children and adolescents with autism is more modest than levels of improvement seen in neurotypical patients with comparable levels of ADHD. We're now going to talk about the treatment of repetitive behaviors in patients with autism spectrum disorder, specifically talking about antidepressants. We're going to start with talking about a case. B is a 24-year-old woman with autism spectrum disorder with frequent echolalic speech and obsessional interest in Disney videos. The parents' main concern are ritualized behaviors that are making it hard for caring for B at home. B has a ritual of flushing household items down the drain, damaging the pipes and items around the house. B may throw out furniture or wall hangings if an item is novel or if the caregivers and parents rearrange the home environment in some ways. The patient cannot clearly explain a reason for this behavior, to explain exactly what it is that they want to be different, but they will repetitively do this behavior, and it's made it very hard to induce any change at all within the home environment. Repetitive behaviors are among the most common concerns presented by caregivers when it comes to a patient with autism spectrum disorder. Parents are concerned that this may represent OCD, obsessive compulsive disorder. They'll describe it as that. and come to the clinician asking about medications that might reduce this symptom. It's important for the clinician to understand these repetitive behaviors and ask themselves whether it's really the same thing as obsessive-compulsive disorder as we understand it in neurotypical populations. Many of the core symptoms of autism spectrum disorder can result in repetitive behaviors that can be misunderstood as being obsessive-compulsive disorder. For instance, stereotypy has a very repetitive ritualized quality to it. For instance, hand flapping or toe walking. Individuals can engage in very ritualized behavior that needs to be done in a very specific way. That sometimes can include tapping or touching certain items, which can look more like OCD. Restricted interests or obsessions in certain things such as numbers or letters can look very similar to symptoms of obsessive-compulsive disorder as well. And insistence on sameness, needing to follow a very specific routine when it comes to timing. Family might also describe this as OCD. But OCD and the repetitive behaviors and insistence on sameness in autism likely represent distinct clinical entities. To highlight this point, there was a study that was done in 1995 that conducted a standardized assessment to individuals with classic obsessive-compulsive disorder and individuals with autism spectrum disorder using the Y-BOX, the Yale-Brown obsessive-compulsive assessment tool. When it comes to repetitive thoughts, we call those obsessions. In general, they were more common in patients with OCD as compared to patients with autism spectrum disorder. Contamination obsessions in particular, or fear that an individual is going to engage in aggression, a need for symmetry, somatic obsessions, these were all way more common in individuals with obsessive-compulsive disorder as compared to autism. When it came to compulsions, repetitive behaviors, repetitive cleaning and checking for safety, an example of that might be checking that the doors are locked or that the oven is off. These were way more common in patients with obsessive-compulsive disorder as compared to autism. So those repetitive behaviors appear to be much more common in OCD and can be a way that clinicians can distinguish when they're hearing about repetitive behaviors what is a clinical entity of OCD in an individual with autism, because comorbidity can happen, or whether this may represent more the rituals that are the core symptoms of autism itself. A further point that drives home the distinct nature of these two different clinical entities are studies of serotonergic drugs in patients with autism. There have been multiple large double-blind placebo-controlled trials of selective serotonin reuptake inhibitors in children with autism for the treatment of repetitive behaviors that have not shown improvement. Moreover, some of these trials showed high levels of discontinuation rate of SSRIs in kids with autism due to side effects such as irritability, agitation, with discontinuation rates in the 16% to 23% range, which is higher than in trials of SSRIs in neurotypical population. This finding is contrasted somewhat by adults with autism. There are some smaller trials of SSRIs and clomipramine in adults with autism that have shown some improvement in repetitive ritualized behavior. So this is leading to essentially the take-home that there may be some benefit for the usage of SSRIs and clomipramine in adults for repetitive behaviors in autism, but the evidence appears pretty clear for it not helping children with autism. A recent meta-analysis that was conducted in 2020 and published in 2021 also emphasized that serotonergic medications don't appear to be helpful for repetitive behaviors in autism spectrum disorder. There was a small benefit in terms of repetitive behaviors with the usage of antipsychotic medications, though of note, those are all trials where the patients with repetitive behaviors also had substantial aggressive behaviors or irritability. And the improvement of irritability may be a mediating factor in whether or not the repetitive behaviors actually improve. One final point to make about serotonergic acting medications in children with autism spectrum disorder is to talk a little bit more about the details of the side effects that can happen with SSRIs. A trial that was done in 2009 by King et al. That was published in Archives of General Psychiatry in children with autism spectrum disorder with significant repetitive behavior. This trial used low dosages of citalopram. And side effects that were seen included increased energy level, impulsiveness, decreased concentration, hyperactivity, increased stereotypic behaviors, diarrhea, insomnia, dry skin, or pruritus. So what should the clinical approach be to repetitive behavior? Clinicians should recommend that patients maximize behavioral therapies such as applied behavioral analysis for the treatment of repetitive behaviors in autism. The prescribing clinician should assess for other psychiatric or behavioral comorbidities that may be responsive to a medication, such as aggressive behaviors, irritability, hyperactivity, or insomnia. It's possible that treating those comorbidities with medications might have downstream effects in reducing ritualized behavior. In adults, it may be worth pursuing an SSRI trial versus clomipramine due to some better evidence for improvement in this population as compared to children with autism. So key take-home points from this section. Repetitive behaviors in autism spectrum disorder and symptoms of obsessive-compulsive disorder are likely distinct clinical entities. OCD can be most reliably distinguished by the presence of obsessional thoughts, particularly those of contamination, symmetry, or fear of aggression, or be distinguished by compulsions specific to cleaning or checking for safety. Multiple well-designed trials of selective serotonin reuptake inhibitors have failed to show benefit for the treatment of repetitive behaviors in children and adolescents with autism. On the other hand, research suggests some potential benefit for SSRIs and clomipramine in treatment of repetitive behaviors in adults with autism. The approach to the treatment of repetitive behaviors in autism should emphasize behavioral therapies, such as applied behavioral analysis, ABA, and the assessment for comorbid symptoms such as hyperactivity that might respond to medications. Next, we're going to talk about the treatment of depression and anxiety in patients with autism spectrum disorder, antidepressants, and other strategies. We're going to start with talking about a case. Mr. C is a 20-year-old man with autism spectrum disorder. He was precocious with his language development, speaking in full sentences by 1.5 to 2 years of age. He has a strong science fiction interest. It's a restricted interest. Majority of his time is spent with this interest. He presents to your office complaining of depressed mood and feeling excluded socially by his peers. Despite his intelligence, he's always been the top of his class in terms of academics. As the demands in terms of academics are increasing, his challenges regarding organization are resulting in increased academic struggles. He has a very negative self-concept around his autism, frequently reporting in the appointment, I hate the fact I have autism, I hate my autism. And he has a sort of partial insight into the way in which his autism can make it harder for him to make friends, but doesn't have a whole lot of sense of how to necessarily change that and has frequent feelings of loneliness. He requires constant reassurance seeking around natural disasters and future events, constantly worrying about that in the future. His parents have taken to avoiding watching the news around him or talking about the future for fear that he's going to have constant need to be reassured around this issue. Depression and anxiety represent another common treatment target for the prescribing clinician caring for kids, teens, and adults with autism spectrum disorder. At the time of this recording for this lecture, there are still no medication-based studies of SSRIs or any medicine for the treatment of depression in patients with autism spectrum disorder. It's kind of a glaring omission at this point in terms of the research field. There's a real need for double-blind, placebo-controlled trials of medication, SSRIs, for the treatment of depression in people with autism. SSRIs may carry more challenges with tolerability among patients with autism as compared to neurotypical populations. And then, of course, SSRIs carry a black box warning in children and young adults, neurotypical, but the same warning applies for patients with autism spectrum disorder and is worth talking about with caregivers and patients. Black box warning to watch for suicidal ideation. The clinical approach for the treatment of depressive disorders in patients with autism spectrum disorder still follows the treatment approach for the usage of these medications in neurotypical children and teens with depression. SSRIs, bupropion, mirtazapine, SNRIs, serotonin norepinephrine reuptake inhibitors may all be considered for the treatment of depression. It's also worth being careful of the prescription of bupropion in patients with autism spectrum disorder, as it can lower the seizure threshold. It's important to screen for whether patients with autism have existing seizure disorders before starting bupropion and discussing with their neurologist and with the patient, the risk for a return of seizures if you prescribe that medicine. When it comes to anxiety in autism spectrum disorder, there are a couple of points that are worth making. In minimally verbal, nonverbal patients with autism spectrum disorder, there will always be some uncertainty as to the patient's emotional state. If the caregiver is bringing in the minimally verbal child with autism, reporting severe outbursts and wondering whether anxiety may be a precipitant, the clinician should ask, what are some common triggers that might come before an outburst or an agitated state? It can be very helpful when assessing outbursts or agitated states in minimally verbal patients with autism to look at the antecedents that come right before the outbursts. This is kind of like conducting a chain analysis. For instance, an outburst might occur prior to anticipated separation or exposure to a dog. All these things may build the case for it being more anxiety-related, where if it's non-preferred demands or denied access to preferred activity or food, that might suggest more a problem with anger management in general. There's one important trial that's worth talking about when it comes to buspirone. This is an open-label trial, 8-week trial in 22 subjects that had autism spectrum disorder. The majority had higher functioning autism spectrum disorder, and the age range was 6 to 16 years old. These were all subjects, well, the majority of them were inpatients, so their issues with anxiety were so severe that they were hospitalized for them. Clinicians could use flexible dosing and ended up on a mean dosage of 30 milligrams with a range of 15 to 45 milligrams per day. And the target symptoms were the treatment of anxiety or co-occurring anxiety and irritability. The findings of this trial, the outcome measure used was the Clinical Global Impression Improvement Scale, the CGI-I, where clinicians were asked to rate whether someone had very much improved or marked response, moderate improvement, mild improvement, no improvement, mild worsening, moderate worsening, or very much worsened. And 9 subjects taking buspirone had very much improvement or marked response, and 7 subjects had moderate response. The medication was very well tolerated. Some initial sedation, slight agitation, initial nausea were some side effects that were seen. One subject had reversible mouth movements, similar to sort of tardive movements of the mouth. They improved with stopping of the medicine. All subjects who responded on the medicine stayed on, and the improvement that was seen was present at follow-up, a mean of 5.4 months. Even though this is an open-label trial, I bring it up only to emphasize to clinicians that buspirone should be considered in patients with autism spectrum disorder for the treatment of anxiety where there may be challenges with tolerability of SSRIs. Even in severe cases of anxiety, buspirone can still have an impact. So the clinical approach to the treatment of anxiety disorders in children with autism spectrum disorder, clinicians should consider buspirone as being a potential first-line agent. Mirtazapine or selective serotonin reuptake inhibitors should be considered as well. Alpha-2 agonists are used for the treatment of hyperactivity, but because they can have effects on decreasing the fight-or-flight response mediated by norepinephrine, they can sometimes be considered as calming agents that might help with anxiety. And similarly, beta blockers such as propranolol or long-acting propranolol may be considered. And benzodiazepines can also be effective for reduction of anxiety in this population. A couple of key points to take home from this section. Psychopharmacology for the treatment of major depressive disorder in patients with autism spectrum disorder has, at this point, little research to guide clinicians. SSRIs may carry more challenges with tolerability among patients with autism as compared to neurotypical populations. Clinicians should consider a trial of buspirone for the treatment of anxiety in patients with autism spectrum disorder in light of superior tolerability. Next, we'll talk about the treatment of irritability in autism spectrum disorder, specifically atypical antipsychotic medications. We'll start with talking about a case. Miss D is a 17-year-old minimally verbal woman with autism spectrum disorder and a profound insistence on sameness, ritual, and routine. The caregivers had a plan to care for D in the family home into her adult years, but they're bringing her to you for treatment because there have been escalating problems with aggression and self-injury that have made the parents not confident they can care for D into adulthood. With small limits or changes in her routine, D is increasingly engaging in more forceful headbanging, aggressive strikes, and pinching towards caregivers. Dad's declining health has resulted in him not being as available to provide daytime structure outside of school, and D has more open-ended time, which seems to have perhaps worsened some of these behavioral concerns. The treatment of irritability is a very common reason for patients with autism spectrum disorder to be brought to the prescribing clinician in both higher functioning patients with autism as well as patients with autism with co-occurring substantial intellectual disability. We might understand the construct of irritability as being around problems with emotional regulation, frustration tolerance, a quick progression to unsafe behaviors such as aggression, self-injury, throwing items, property destruction, elopement, in response to non-preferred demands, such that families are walking on eggshells. The first trial I want to talk with you about is risperidone for the treatment of irritability. This was a trial that was done by the RUP group, a group of academic institutions that pooled their resources to study the treatment of medication-based interventions for behavioral concerns, in this case, in patients with autism. This was a trial that was 82 boys, 19 girls, mean age of 8 years old. Subjects had to have significant irritability as measured using the Aberrant Behavioral Checklist Irritability Subscale when they entered into the trial. It was an 8-week trial. It was double-blind, placebo-controlled parallel groups. The clinicians were allowed to use flexible dosing in the range of risperidone, 0.5 milligram to 3.5 milligrams per day. A responder was judged as someone who had a 25% reduction in the Aberrant Behavioral Checklist Irritability Subscore. You had to have a 25% reduction and then also be rated as very much improved or much improved on a measure called the Clinical Global Impression Improvement Scale, the CGI-I. Much improved or very much improved is a responder. That plus the reduction in the ABCI score. So it was a high standard in terms of whether or not someone was a responder or not. This figure I want to show you here has to do with showing the percent of subjects that responded taking risperidone versus placebo. You'll see 34 out of the 49 subjects taking risperidone were responders as compared to only 6 taking placebo. So certainly a positive trial attesting to the benefit of risperidone. If we dig a little bit more into the results, there was a reduction in stereotypy and also hyperactivity. So while I wouldn't think about risperidone as necessarily being a treatment for ADHD, in this case, these were subjects that were very aggressive, there may be a reduction in hyperactive symptoms with the usage of risperidone, and this is not unusual to see this area improve. Adverse events that were seen in this trial, the most important to talk about is weight gain. A weight gain of 2.7 kilograms in just this short 8-week trial. And that was compared to a weight gain of 0.8 kilograms among the placebo population. In addition to increased appetite, fatigue, drowsiness, dizziness, and drooling were all more common in the risperidone group. There were not differences in extrapyramidal symptoms, things like focal dystonias, Parkinsonism, or akathisia. But again, this was just an 8-week trial. One important thing to talk about with the usage of risperidone is the potential risk for hyperprolactinemia. The usage of antipsychotics with relatively high D2 affinity, such as risperidone or haloperidol, for instance, warrant monitoring for symptoms of hyperprolactinemia. Symptoms of hyperprolactinemia that are important for the clinician to watch for include suppressed or abnormal menstruation, gynecomastia, galactorrhea, bone demineralization, or decreased libido. Monitoring prolactin levels can prompt the clinicians to remember to ask about these symptoms. When elevated prolactin levels are combined with symptoms of hyperprolactinemia, the clinical symptoms I talked about, clinicians should consider decreasing the dosage, changing agents away from risperidone entirely, or, in severe cases, adding a dopamine agonist, such as a low dosage of aripiprazole, which can actually decrease prolactin levels and may reverse the side effect of concern. Another important side effect to talk about with risperidone in greater detail is metabolic syndrome and weight gain. There was a trial that looked at metformin for the treatment of weight gain in individuals with autism who had to take risperidone or aripiprazole for the treatment of irritability. This was a 16-week trial, double-blind, placebo-controlled, 60 subjects with ages 6 to 17 years. These were all subjects that had weight gain from atypical antipsychotics used to treat irritability. These subjects had to be stable for 1 month with the dosage of the antipsychotic medication and had about a 7% increase in BMI. So that was sort of the trigger for them moving forward with this trial of metformin. The dosing was 500 milligrams twice a day given in meals. to 6 and 9-year-olds who participated, and 850 milligrams twice a day for subjects 10 to 17 years of age. The primary outcomes were whether metformin was tolerable and safe, and whether or not there was a decrease in the rate of increase of BMI, as measured using a Z-score. The results of this trial indeed showed that metformin was helpful for reducing the rate of weight gain induced by medications like risperidone and other atypical antipsychotic medications for irritability and autism. The mean weight gain from metformin over the duration of the 3-month trial was less as compared to placebo. And 11% of subjects taking metformin actually had a BMI decrease of 8 to 9%. Of note, the differences in terms of the rate of weight increase was not apparent until after 8 weeks. So it's important not to give up on metformin too soon. Giving it a trial of 2 to 3 months is necessary in order to determine whether or not there's real benefit. Metformin was tolerable in this patient population. The major difference was the frequency of days of GI complaint. GI complaints included things like abdominal discomfort, diarrhea, bloating, or flatulence. There was one subject in the metformin group that had significant agitation and had to leave the trial for that reason. In finishing up this section, I'll briefly mention a trial that was done in aripiprazole and autism. This was a drug company-funded trial of 98 subjects in children and adolescents with autism ages 6 to 17 years old with substantial irritability. It was an 8-week double-blind placebo-controlled trial with a dosing range between 2 and 15 milligrams per day. Subjects ended up on a mean dosage of aripiprazole of 8.5 milligrams per day, and they had greater reductions in the ABC irritability subscale as compared to placebo. That was a significant difference. So it was also a positive trial attesting to the improvements in irritability with aripiprazole. The most common adverse events were fatigue, somnolence. Weight gain was also seen in aripiprazole, 2.1 kilograms over an 8-week trial as compared to 1 kilogram of placebo in terms of mean differences. So the clinical approach for the treatment of irritability in patients with autism spectrum disorder, clinicians should know there's the best evidence for risperidone and aripiprazole, which both carry an FDA indication for the treatment of irritability. Key points to draw from this section include risperidone and aripiprazole carry an FDA indication for the treatment of irritability in children and adolescents with autism. Metabolic side effects, including weight gain, are common when prescribing antipsychotics for irritability and autism. Weight gain with antipsychotics in patients with autism can be attenuated by adding metformin for patients that gain substantial weight in the first few weeks of treatment. We'll talk about the treatment of irritability and autism spectrum disorder, other antipsychotic medications besides risperidone and aripiprazole, and the functions of parent management training. It is worth talking about some other research studies as to other antipsychotic medications and how effective they can be for the reduction of irritability in autism spectrum disorder. In reviewing the research of alternative atypical antipsychotic medications, it's worth talking about ziprasidone. There was a 12-subject open-label 6-week trial of subjects with autism spectrum disorder between the ages of 8 and 20 years old at dosages between 20 and 160 milligrams. 75% of subjects had improvement in reductions of irritability. The real interesting take-home from this open-label trial was that subjects did not gain substantial weight. That makes ziprasidone stand out as compared to other atypical antipsychotic medications for the treatment of irritability and autism, and may make it a good option to consider in patients who gain substantial weight with treatment as usual, risperidone and aripiprazole. Olanzapine had a double-blind placebo-controlled trial. It was an 8-week trial of 11 preteens. The mean dosage that clinicians landed on was 10 milligrams. 3 out of the 6 had improvement who were taking olanzapine as compared to only 1 out of 5 for placebo. This was a small trial, and the weight gain was substantial with this medication, 7.5 pounds with a standard deviation of 4.8 pounds. The results are more mixed for quetiapine, 4 open-label trials with different results in terms of improvement. And a study of paliperidone of 25 subjects that was open-label in 8 weeks. Subjects were 12 to 21 years old, and 83% of subjects had response at a mean dosage of 7.1 milligrams. Subjects gained weight at a mean of 5 pounds over this 8-week trial, and sedation was the most common side effect. Prior to studies of risperidone and aripiprazole, there were two randomized placebo-controlled trials of haloperidol that was associated with an improvement in a variety of symptoms in patients with autism spectrum disorder, including aggression and irritability. The most common adverse events with haloperidol included focal dystonias and dyskinesias, which were present at a higher rate in this patient population than in trials of atypical antipsychotic medications. Another important trial I want to tell you about in this section is a add-on trial that the RUP group did, looking at patients who were taking risperidone for the treatment of irritability, patients with autism. This was a trial of 124 subjects, 4 to 13 years old with autism spectrum disorder who had substantial irritability. What this trial looked at is whether or not adding parent management training resulted in further benefits in individuals who were taking risperidone for the treatment of irritability. Parent management training is essentially teaching parents and caregivers the core concepts of behavioral therapy and applied behavioral analysis. The concept of antecedent behavior consequence to understand a behavior, and then using structured reinforcement system to craft behavior, learn new behaviors, or reduce problematic behaviors. Parent management training was delivered as meetings with a parent on a once-a-week basis to teach the concepts of behavioral therapy. Outcome measures included the ABC irritability scale that's used in most of these trials to measure the severity of irritability, as well as home situations questionnaire to get a sense of the safety and manageable nature of behaviors at home. What was found from this trial was that families who had parent management training added were more likely to be on lower dosages of risperidone than in families who were just getting risperidone without parent management training, a mean of 2.26 milligrams as compared to 1.98 milligrams per day, a significant difference. This is just a reminder to the clinicians to also be assessing for whether or not patients are receiving high-quality applied behavioral analysis or behavioral treatments through home and school. When these behavioral treatments are delivered at home, the behavioral clinician can teach parents and caregivers to use some of these same techniques in order to manage behaviors, and this can allow for lower dosages of medications. Coming again to the clinical approach to the treatment of irritability, best evidence exists for risperidone and aripiprazole, but as emphasized in this category, clinicians may think about the usage of ziprasidone to manage irritability with less risk for weight gain. There's more modest evidence for quetiapine, olanzapine, and paliperidone, and some evidence for the usage of haloperidol, albeit with higher levels of extrapyramidal symptoms. Key points to take home from this section. Data from open-label studies in autism spectrum disorder suggests less weight gain with ziprasidone as compared to other atypical antipsychotic medications. Consider ziprasidone among the first-line treatments for irritability and autism spectrum disorder in light of reduced weight gain. Studies of haloperidol suggest good efficacy for the treatment of irritability and autism, but higher rates of movement side effects as compared to atypical antipsychotic medications. Parent management training teaches parents the concepts of applied behavioral therapy. When added to a treatment plan, it may reduce the dosage of medications required to achieve effect. We're going to talk about the treatment of irritability in autism spectrum disorder, specifically other mood stabilizers and strategies. There have been some studies of divalproic sodium, or valproate, for the treatment of irritability in autism spectrum disorder, and the results are mixed. One trial of 30 subjects of children, a mean age of 11, showed no improvement in aggression, but a larger trial of 55 subjects with a mean age of 9.5 years of age did show improvement with irritability. The most common adverse events were sedation, weight gain, behavioral activation, and digestive disturbance. We might think of that as being nausea or bloating. Oxcarbazepine was looked at in a retrospective case analysis, 30 subjects between the ages of 5 and 21 years old. 47% of patients had much improvement, which was measured using a clinical global impression improvement scale in a retrospective manner. 23% of subjects discontinued due to adverse events, worsened irritability being the most common side effect with this medication. There was a placebo-controlled 8-week trial of lamotrigine in 35 subjects with autism spectrum disorder. This was a younger patient population with a mean of 5.8 years of age. This study did not find improvements in irritability as compared to placebo. Topiramate may carry some benefit and can reduce appetite increase rather than increase it, making it a treatment that may reduce irritability, but also reduce some of the weight gain related to antipsychotic medications and can therefore be a helpful augmenting agent. And a retrospective case analysis of 19 subjects with irritability and autism spectrum disorder with lithium was conducted. In this trial, subjects were 15 to 36 years old. They categorized subjects using an evaluation of the charts, using a CGI as their outcome measure, rating a subject as very much improved, much improved. They were somewhat vague in terms of what was measured as improvements, maladaptive behavior. So we're a little less certain that this was necessarily irritability that they were talking about, and that should hedge a little bit of our confidence with the usage of lithium. But there were 10 subjects that showed much improvement or very much improvement. The most common side effects were lethargy and tremor in this patient population. Clinicians should also think about the usage of as-needed medications for the treatment of irritability and autism. Developing an effective, tolerable, as-needed medication plan for patients with irritability can be very helpful for families and reduce the standing dosage of medications needed. Situations where irritability is largely well controlled with some breakthrough episodes of agitation that are not very common but of major concern when they happen is a scenario where a clinician should really be thinking about the usage of a PRN, an as-needed medication, rather than increasing the standing dosage, especially if caregivers or parents can see certain behaviors as signs that an individual is getting more agitated. Effective as-needed medications for the treatment of irritability and autism include alpha agonist medications, specifically clonidine, benzodiazepines, particularly lorazepam or alprazolam, that may be rapid or medium quickness in onset, or as-needed dosages of antipsychotic medications. Risperidone, olanzapine, quetiapine, or haloperidol all lend themselves to effective calming effects and may be considered as needed treatments. All as-needed medication plans should be developed with clear instructions to caregivers regarding the maximum allowed dosage in 24 hours, as well as how close together as-needed medications can be given. The usage of as-needed medications can reduce the likelihood that a family will need to bring their loved one to an emergency room. So, given the concerns regarding getting stuck in the emergency room awaiting hospitalization for days or weeks, even in some cases, is more likely to happen in patients with autism spectrum disorder. Thinking carefully about an as-needed medication plan can help avert this situation and reduce the frequency with which this patient population needs to be hospitalized for behavioral reasons. When it comes to the treatment of irritability, again, the most evidence-based approach includes the usage of antipsychotic medications, risperidone and aripiprazole particularly, which carry an FDA indication. Alternative antipsychotic medications, such as ziprasidone, with its decreased risk for weight gain, quetiapine, olanzapine, haloperidol, and paliperidone have all been studied and have some studies showing improvement. Clinicians should also consider anti-seizure medications, such as oxcarbazepine, and we may consider carbamazepine as well, given some of its similarity in mechanism of action as compared to oxcarbazepine. Valproic acid and lithium, while not weight neutral, do carry some evidence for reduction in irritability. A couple key points to draw from this section. Anti-seizure medications and lithium have less research into their efficacy for irritability and autism. However, they are used in clinical practice, and they may provide clinical benefit. Anti-seizure medications may be considered if antipsychotics are intolerable or if subjects suffer from both poorly controlled seizures as well as irritability. In cases of only mild to moderate improvement with an atypical antipsychotic, consider adding an augmenting agent or as-needed medication before adding a second antipsychotic medication. As-needed medications can be helpful in reducing the likelihood of ER stays or even decreasing the standing dosage of a medication. We are going to talk about the treatment of sleep disturbances in patients with autism spectrum disorder, melatonin, and other strategies. We're going to start with talking about a case. E is a 13-year-old boy with autism spectrum disorder and moderate intellectual disability. He had excellent sleep with moderate dosage melatonin. He was home from school for a prolonged period, and over the summertime got used to staying up late on his tablet, looking at preferred interests and preferred videos. After doing this for a period of a number of months, it is now taking him hours to fall asleep. And getting into the habit of waking mid-cycle to look at his tablet are such that he has now a pretty disrupted pattern of sustained sleep. It's a major concern when he wakes mid-cycle, as he may wander the home and end up in unsafe situations while parents are sleeping. The treatment of sleep disturbance is also a common main concern for a lot of caregivers and parents of a patient with autism spectrum disorder, or a chief complaint of an individual with autism spectrum disorder themselves. Melatonin has 13 control studies for the treatment of sleep disturbance in children with neurodevelopmental disorders. This amounts to 424 subjects in total. This is a well-researched area. Parallel groups, crossover designs, with dosages of 1 to 10 milligrams that have been studied. Melatonin is superior to placebo in all 13 of these trials, with the majority of these trials showing mild side effects, if any, and oftentimes not differing than placebo in terms of the presence of side effects, leading melatonin to be an easily recommendable medication in terms of effect, as well as tolerability for the treatment of sleep disturbance in children with neurodevelopmental disorders. There's been little in the way of other double-blind placebo-controlled trials of other medications for the treatment of sleep disturbance and autism spectrum disorder. So further guidance past melatonin is based more on clinical practice. My approach when it comes to the treatment of sleep disturbance includes starting with melatonin. Clinicians may consider the usage of clonidine or trazodone, especially in younger populations. Clonidine being a particularly effective choice for problems with sleep initiation, and trazodone being a more effective treatment choice for patients who have disrupted sleep cycle or mid-cycle awakening. Mirtazapine can be very effective as a treatment of sleep challenge. Clinicians should be careful for the risk for weight gain with this medication. In more severe cases, tricyclic antidepressants may be considered. Clinicians should watch for the potential risk for tricyclic antidepressants being harder to tolerate in children, particularly children with autism spectrum disorder, and watch for irritability and starting at low dosages and moving slowly with the dosing. Medications like diphenhydramine or even benzodiazepine medications should be used with caution in patients with autism spectrum disorder because of a risk for paradoxical response. This is to say, rather than being calmed by these medications, some children with autism spectrum disorder can become activated, more energized, or even agitated at higher dosages, silly, giddy, goofy, disinhibited, or even irritable with these medicines. Clinicians may therefore put them a little farther back in terms of when to consider these medications and discuss this possibility with parents before they initiate medication trials or with individuals with autism who can consent to treatment. A couple of key points to draw from this section. There are an abundance of blinded placebo-controlled trials for the usage of melatonin for the treatment of insomnia in autism spectrum disorder. These trials attest to the effectiveness of this medication and excellent tolerability. Diphenhydramine and benzodiazepines have been noted in clinical practice to carry higher risk for paradoxical reactions in patients with developmental disability. We'll talk about the treatment of impaired social relatedness in patients with autism spectrum disorder. There have been a large number of high-quality double-blind placebo-controlled trials looking for a medication-based treatment for social functioning in patients with autism spectrum disorder. Unfortunately, there are still no evidence-based medication treatments for social impairment in autism as of the time of this recording. A large number of medications for which there was some hope, such as oxytocin, for instance, or amantadine, have had recent double-blind placebo-controlled trials that have unfortunately failed to show improvement. Further trials into these agents may look to see whether or not certain people with autism may respond better than others, but unfortunately right now, there's not good evidence that would recommend their usage in patients with autism. Agents with promising initial research that are still under investigation include vasopressin, folic acid or leucovorin, sulforaphane, bumetanide, D-cycloserine, All these medications have initial studies suggesting some promising effect, but these trials have not yet had a large double-blind placebo-controlled trial with convincing evidence accepted by the majority of autism specialists. So clinicians should think about non-medication-based treatments when they're trying to help their patients with social impairment related to their autism spectrum disorder. Many patients can benefit from applied behavioral analysis in improving social impairment related to their autism spectrum disorder. In fact, this may be considered particularly in patients who have co-occurring intellectual disability. Treatment goals with applied behavioral analysis include pro-social behavior that may be rehearsed. For instance, training an individual with autism spectrum disorder to provide a greeting and to engage in social approach behaviors, for instance, using a reward system. More common approaches are the usage of social skills groups. For younger kids, teens, and adults with autism spectrum disorder, these social skill groups involves teaching a specific concept, like making small talk or respecting personal boundaries, and include a peer group with similar social challenges, where there's a specific activity like a movie night, for instance, or board game night, a chance to practice that particular concept. These groups typically have a neurotypical group leader to ensure inclusion and that the task of learning is focused on. In patients who have higher functioning autism spectrum disorder, clinicians may think about recommending additional treatments for social impairment. Some examples of this treatment I will review here. Some teaching curriculums have a formal approach to the treatment of social skills and competencies. These are didactic approaches like social thinking curriculum, for instance. It can be school-based or clinic-based, and essentially it's a very didactic approach. In patients who have higher functioning autism spectrum disorder, clinicians may consider adding individual psychotherapy with a clinician experienced in working with individuals with autism spectrum disorder. They may couple meeting with a therapist along with an affinity group around an area of interest, such as photography or history, where that individual with autism spectrum disorder can interact with neurotypical peers who share their particular interest, and then check in with a clinician at a later time to talk through challenging interactions with peers. Couples therapy can be a wonderful modality in terms of making progress in social functioning, particularly showing and understanding the concept of reciprocity within relationships. Increasingly, there are couples therapists and coaches who work with neurodiverse couples, and this can be a wonderful forum to learn more about the concepts of intimacy in a relationship, understanding an intimate relationship versus a more superficial one. Therapeutic mentors can also provide important feedback for individuals with autism spectrum disorder about how they do with navigating social relationships. And clinicians should also think about welcoming social peer groups and work environments who can be understanding and supportive around individual social differences related to their diagnosis. A couple of key points to draw from this section. There are currently no medication-based treatments for social impairment in autism spectrum disorder that have a definitive research basis. Patients with both higher and lower functioning autism spectrum disorder can both make progress in social functioning with behavioral, educational, and psychotherapy-based treatments. Some final take-home messages reviewing the most important key points on this topic of the usage of medications for the treatment of behavioral concerns, psychiatric comorbidities in kids, teens, and adults with autism. Autism is a lifelong neurodevelopmental disorder, expected to show its symptoms in early developmental stages and have its effects throughout the life course of an individual. Behavioral therapies, and when appropriate, psychological therapies, should be offered to patients with autism spectrum disorder, in addition to medication-based treatments for behavioral concerns. There are no evidence-based medications for the core symptoms of autism. However, psychopharmacology can be helpful for common comorbidities, such as hyperactivity, irritability, insomnia, anxiety, and depression. Using caution when prescribing is especially important in patient populations with autism spectrum disorder who may have higher rates of medication side effects. There's plenty of reason to think that patients with autism spectrum disorder may have more difficulty tolerating medications, particularly serotonergic medications, as compared to neurotypical populations. Psychostimulant medications can be effective in reducing hyperactivity among the full range of severity of patients with autism spectrum disorder. Research of alpha-2 agonist medications and atomoxetine suggests improvement in hyperactive symptoms in children, teens with autism spectrum disorder with superior tolerability to stimulants. Research suggests some potential benefit for SSRIs and clomipramine in treatment of repetitive behaviors in adults with autism spectrum disorder. However, the approach to treatment of repetitive behaviors in ASD should emphasize behavioral therapies, such as applied behavioral analysis, and the assessment for comorbid symptoms, such as hyperactivity, that might respond to medicines. Risperidone and aripiprazole carry an FDA indication for the treatment of irritability in children and adolescents with autism spectrum disorder. Consider ziprasidone among first-line treatments for irritability in autism spectrum disorder in light of reduced risk for weight gain. There is an abundance of blinded, placebo-controlled trials of melatonin for insomnia in autism spectrum disorder, which attests to its effectiveness and excellent tolerability. Adding behavioral treatments, such as applied behavioral analysis when available, may reduce the need for and dosage of psychotropic medications. Thank you for your attention.